Good morning. Thank you very much, first of all, for the invitation. I had a very good reason to come all over from Greece to the United States in this situation. I will talk now about our approach to the treatment of patients with AL amyloidosis who are not candidates for transplant. So we're going to move in a different direction from what Dr. Dispengeri showed. These are my disclosures. And I will start with a case of a 63-year-old male with a non-monoclonal gammopathy for several years. Also had mild hypertension, started developing dyspnea, peripheral edema, dizziness, and low blood pressure, had discontinued hypertensive. Typical findings in the ECG and the echo. And as you can see at the time of evaluation, the NT-proBNP was more than 6,500 picograms per ml, and high sensitivity troponin was 59. Low serum albumin, marginal renal function, eGFR of 59, and proteinuria of 7 grams per day. A small M spike and the free light chain abnormal with a lambda of 331 and a difference between the free light chains of above 300 milligrams per liter. 15% clonal plasma cells, and in the cytogenetics by FISH, the patient had T1114. So this patient was diagnosed with AL amyloidosis according to the staging system that Dr. Dispengeri showed, had Mayo stage 3A, a revised Mayo 2012 stage 4, and renal stage 2 disease. And the first question is, how are you going to treat this patient? Are you going to start therapy with daratumumab VCD? Are you going to start with VCD and add daratumumab if you don't see a response after 3 cycles? Are you going to start with daratumumab and add bortezomib if you don't see a response by 3 cycles? Are you going to start dara VCD and reevaluate this patient for transplantation because you are not convinced that it's not eligible for transplantation? Or are you going to give him BMDEX, which is a regimen that is not preferred for patients who are transplant eligible, but this is a transplant ineligible patient in your opinion. And also BMDEX has shown survival benefit. So we will wait a few seconds for your votes. I'm not sure there is a single correct question to that, answer to that, but we'll see how the voting goes. Can we move?
They'll show you the response. Yep.
All right. So 55% would start therapy with dara VCD, and a significant proportion of the audience would also reevaluate this patient later on for transplantation. Start dara VCD and reevaluate for transplantation. I think both are very reasonable approaches. In my center, we don't use transplantation that much, so I would go for the A, but I think also D is a very, very reasonable approach. So the second patient is a 75-year-old female, again with a typical history of hypertension and a known MGUS. About 1 year ago, she presented with dyspnea, lower leg edema, and especially in the last 3 months, she started having lower leg pain that does not let her sleep. He has evidence of perhaps amyloidosis, not very typical in the ECG and echo, an NT-proBNP of around 3,000, high sensitivity troponin 37 picograms per ml. Serum albumin is normal liver function tests, an eGFR of 42, and the proteinuria of 3 grams per 24 per day. She has symptoms, signs, and objective evidence of peripheral neuropathy. She is having painful neuropathy, and she's receiving pregabalin and opioids. Her free light chains are increased, not very high. The difference between the free light chains is 90 milligrams per liter. 80% clonal plasma cells. The cytogenetics do not show T1114 or any other major translocation. There is only deletion 13q. And a diagnosis of amyloidosis is made, and For this diagnosis, we used a renal biopsy. So this is a patient with stage 2 per Mayo, classical Mayo stage AL amyloidosis, stage 2 per revised Mayo 2012, and renal stage 2 disease. So what is the approach in the treatment of this patient? Start again therapy with dara-VCD, start VCD and then add daratumumab, or start with daratumumab and then add bortezomib. Someone may consider that this patient could be transplant eligible. She's cardiac stage 2. Or start BMDEX because she's not transplant eligible, and BMDEX has shown overall survival benefit. So again, I will wait for your votes. Again, there may be more than one approaches to specific patient. And we will wait. Okay, let's see whether we will have a different approach from the previous patient. Again, 67% of the audience would prefer to start therapy with dara-VCD. It's the approved regimen. However, a problem with this patient is the presence of peripheral neuropathy. And I would be very careful in adding bortezomib in a patient who is already in a lot of drugs to manage her symptoms because of neuropathy. I would prefer to start daratumumab, and if I don't get a response, then I would consider either bortezomib, or perhaps in some cases, one could consider perhaps an IMiD such as lenalidomide. But this gives us the initiative to start further discussion. First of all, why our patient is not transplant candidate. And the reason is very important for the choice of therapy. Because the patient may not be transplant eligible because of age or other comorbidities, or because of advanced amyloidosis, because it's Mayo stage 3 or stage 3B, renal stage 3. And I think these two cases should be managed differently. And also we have to remember that there is always patients' preferences, and there are also logistic issues that do not allow us to move directly to transplant. But I think the two first reasons are very critical for the choice of therapy. And should these transplant-ineligible patients be managed with the same or similar therapy? We do have two possible answers. One is yes. Anyway, there is only one officially approved therapy, daratumumab with VCD, and everyone should receive daratumumab with VCD. And the other is that no, that treatment should be risk-adapted and should be individualized. No is the obvious answer. However, it's not that easy, and we don't have so many different drugs to individualize the treatment in our patients. And also there is the question of how do we individualize the treatment. So first of all, what are the goals for therapy for our patients? We want to achieve a hematologic response, and also we want to achieve an organ response. So we have two levels of response in AL amyloidosis. First of all, hematologic response, which is required in order to achieve organ response and improve the outcomes of our patients. However, the depth of response is critical for the management of patients with AL amyloidosis, and there is a question of what is an adequate hematologic response. Also, the timing of response, how fast we want to get to this response, is critical. And how fast is fast enough? How much can we wait? In the questions, there was a 3-month period to decide whether we should add something to treatment. Is this okay? And organ response is depending on hematologic response. We have to remember that often lags behind hematologic responses, and there is always a lower probability of organ response where there is more advanced organ dysfunction. And for some of our patients, there may be non-reversible organ dysfunction, especially for patients with very advanced cardiac or renal disease. And what are the criteria to evaluate hematologic response? I will very briefly show the criteria for complete hematologic response and very good partial response, which are the levels of response that we consider as good enough. There is, of course, an issue with the normal free light chain ratio required for the complete hematologic response, especially with therapies such as daratumumab, which also affect the uninvolved free light chains and may cause some confusion. But in any case, what we know is that these response criteria are associated with outcomes, and as you can see, definitely patients who achieve a complete hematologic response or a very good partial response do have a better outcome, and this should be the goal for hematologic response in our patients. Is this enough? We have now the ability to evaluate the presence of minimal residual disease, and as you can see, as we go to deeper hematologic responses, we do get higher rates of organ responses. Less than 60% of our patients in complete hematologic response achieve an organ response, but this goes very high with patients who are in complete hematologic response and also MRD negative. So MRD negativity should probably be the future or the current treatment goal for our patients if this is possible to do with the current therapies. This is also associated, the absence of minimal residual disease, with a lower risk, substantially lower risk of hematologic relapse, which will require second-line therapy. So this is another goal that we should consider for our patients with AL amyloidosis. Now, we have also to discuss about how fast we need to get to this level of response. So in this retrospective study, you can see that patients who achieve a very good partial response within the first month of therapy, they do better than those with partial response. This difference is even more obvious after 3 months of therapy. So this should be enough. No, I'm not sure. Because as you can see here, so the orange line is patients who achieved a very good partial response after 1 month of therapy, and green is patients who achieved a very good partial response after 3 months of therapy. So as you can see in this slide, even the delay to achieve a very good partial response of just 2 months had detrimental effects in the outcome of the patients. And also, less than 25% of the patients who had not achieved a very good partial response after 1 month improved their response to very good partial response at 3 months. So probably we need to have a very rapid hematologic response, and to do that, we need to have the most effective regimen available. This is also shown in this analysis from the Andromeda study presented by Ashu Vechalekar. As you can see, patients who achieve a very good partial response, at least a very good partial response within 1 month and at 3 months, had a better major organ deterioration progression-free survival. You can see that. It's expected. However, what is very important is also the fact that very few patients who did not have at least a very good partial response within 1 month improve their hematologic responses at 3 months. So this is something that is very important on the way that we follow up our patients. So how do we follow up the response to treatment in our patients who we treat with either induction therapy or without transplantation and only with conventional therapy? So there is a consensus that if we don't have at least a partial response within the first 2 months, this patient should be considered as refractory and reevaluate treatment. I would be more aggressive. In our practice, I think if we don't get a PR within the first month, then we definitely change therapy. If you don't get a very good partial response within the first 3 months, then patients should be considered refractory. I think we all agree to that this should be the minimal target for our patients. If we get to that, then we continue therapy. We can discuss whether we should add maintenance or consolidation. The general approach is to continue therapy for a fixed duration of cycles, perhaps 2 to 3 cycles beyond the plateau response. However, we have to remember that hematologic response has some difficulties in assessing. For example, we have to remember that it is based on free light chains, but the free light chain ratio and the free light chains are affected by kidney function, that about 10 to 20% of patients have baseline low levels of free light chains. We have to remember that the criteria are based only on the free light method. And today, at least in Europe, I don't know here in the US, there are more than 2 different methods to measure the free light chains, and you cannot use interchangeably the different methods. You have to be careful. There is MRD, which I think it's a very useful tool to be evaluated depending on the method and the sensitivity. Also has not been prospectively evaluated, but probably provides significant clinical information in certain cases. And for organ responses, we have to remember that the assessment is based on biomarkers, but these biomarkers are not perfect. NT-proBNP is affected by EGFR and by the use of IMiDs. Proteinuria and EGFR are used to assess renal response, but proteinuria may be sometimes difficult to evaluate at very high levels. The EGFR also is affected by many drugs. We'll have the chance to discuss later with Dr. Havasi all this. And also we have to remember that organ responses may be delayed several months after achieving a complete hematologic response. So how can we achieve these goals? In this slide, you can see a summary of the efficacy of the classical bortezomib-based regimens in first-line therapy, VCD, bortezomib with MDEX, and VRD from a smaller study. You can see that the overall hematologic response rate is around 70 to 75%, about 20 to maximum 25% of complete hematologic responses and organ responses at the range of 25 to 30%. From these regimens, only BMDEX has been evaluated in a prospective randomized study, but against MDEX, which it's an outdated regimen, but anyway, it showed that it improved overall survival along with hematologic response rates. We also try to evaluate bortezomib with lenalidomide and dexamethasone, which is a standard treatment for patients with myeloma, even the very elderly and frail patients with myeloma. As you can see, the hematologic response rates were high. However, the toxicity was also quite high, indicating that even with low doses of lenalidomide, it may be difficult to treat patients with AL amyloidosis, and one has to be very careful in the use of these drugs. And going back to the real-world situation, because these are data from referral centers or from clinical trials, you can see from the EMN23 study, which will be updated tomorrow, that in the general population of patients with AL amyloidosis in Europe, the very good partial response and complete hematologic response rate in patients treated with bortezomib-based regimens is below 40%. So definitely, we do lack efficacy for many of our patients. So andromeda-caine and subcutaneous daratumumab was added to VCD. Patients were receiving daratumumab subcutaneously with VCD for 6 cycles, followed by maintenance with daratumumab for up to 24 months, versus the standard VCD for 6 cycles. Patients with stage 3B disease were not included in this study, and the primary endpoint was complete hematologic response. You have seen the data several times now. You have seen the substantial improvement in the complete hematologic response rate, both in the primary analysis and in the updated analysis, and will also be updated tomorrow. It is also very important that this combination was very effective in some very important pre-specified subgroups, such as patients with stage 3 disease. You can see that the odds ratio was 15. And in patients with T11-14, which we know have a lower response to VCD alone. This was, again, associated with substantial improvement, a doubling of organ responses for cardiac and renal responses at 6 and at 12 months. So if we summarize again these regimens, you can see that indeed the DARA-VCD regimen has substantial better outcomes in terms of hematologic, complete hematologic responses and organ responses compared to the other regimens. However, again, I have to point out that patients with stage 3B disease have been excluded from the randomized studies. So where do we stand now? We have BMDEX, which is the only regimen that has been evaluated prospectively before the Andromeda study. We have VCD, which is considered the standard regimen. However, it is a standard regimen that has never been evaluated prospectively in a randomized study before becoming a standard. and we know that it's not very effective in patients with T1114, which is about 50% of patients with L-amyloidosis. And we do have very limited data for stage 3B patients, but we know that with VCD, we do poorly with these patients. So should all patients receive DARA VCD, and then conclude this presentation? First of all, patients with stage 3B were excluded, as we said. Second, we don't know what is the importance of daratumumab maintenance yet. The study is ongoing. We don't have overall survival data. And what about cyclophosphamide and bortezomib? Do we really need them? Are these regimens necessary? Let's see. First of all, I want to point out, and this is from the Andromeda study, that as you can see, with the addition of daratumumab to VCD, we did not improve early mortality. You can see that in both regimens, the early mortality was identical. Second, what about toxicity? We do know that the toxicity was what we expected from daratumumab and from VCD. The toxicity was different when VCD was discontinued and patients continued with daratumumab monotherapy. But if we go and see, more careful these toxicities, you will appreciate that most of them are not related to daratumumab, but are related to the other components of VCD and are related to bortezomib or to steroids or even to cyclophosphamide. So probably this is not exactly the perfect regimen. And what about patients with stage 3B disease who may not tolerate bortezomib because of hypotension, arrhythmias, etc.? We do have a prospective study which evaluates daratumumab monotherapy in patients with stage 3B disease. The study is ongoing. It will be updated here in ASH. You can see here that the overall survival rate, which is the primary endpoint at 6 months, is 64%, being about 50% at 1 year. So it seems that it works, but not for all patients. And what about consolidation or maintenance in the non-transplant setting? We do have few studies for consolidation only after transplant. We had a small prospective evaluation of daratumumab, 4 infusions of daratumumab, which showed that it may be useful in some patients, inducing very deep hematologic responses if in patients who had not achieved a complete hematologic response. For maintenance, what we do is we get data from myeloma. We don't have many data from studies in AL amyloidosis. We wait for the Andromeda results. And with that, I would like to conclude and say that treatment for AL amyloidosis is wishful thinking probably, should be risk, clone, and patient adapted. But what do we mean by that? So for patients not eligible for autologous transplantation, I think that daratumumab VCD should be the first choice. And if daratumumab is not available, VCD or BMDX are very reasonable choices. For patients with stage 3B disease, I would not go for DARA VCD. I would probably go with daratumumab, either monotherapy or with modifications in the doses of bortezomib or cyclophosphamide or dexamethasone. And perhaps for some patients, I would also consider venetoclax if they have T1114. However, we have to adapt our therapy also to the characteristics of the clone. Already, Angela showed the importance of the higher tumor burden. And for patients who have more than 20% of plasma cells or they have slim crowd criteria and amyloidosis, I would go with a treatment that also includes some type of maintenance. So DARA VCD is the obvious choice. However, we don't know exactly how this translates in our patients with amyloidosis and increased plasma cells. Now, I think the presence of T1114 is very important, and for patients with T1114, I would not go with VCD alone. As you can see, as you saw, their response rates are low. I would go for DARA VCD if available, or BMDX, although there is some retrospective data indicating that may be more effective, but not prospective data. And also, I would consider additional venetoclax as soon as possible if we don't get a response. But our treatment should be also risk-adapted, clone-adapted, and patient-adapted. And patients present to us with many complications because of their disease. And many of the drugs that we use may not be very good for these patients in terms of toxicity. For example, in patients with neuropathy, adding full dose bortezomib may deteriorate their symptoms, or in patients with diarrhea. There are some discussions about whether in patients with heavy proteinuria, daratumumab pharmacokinetics may be affected and may be affecting the efficacy. These are conflicting results. The prospective evaluation in Andromeda did not prove that. And with that, I would like to conclude this presentation and again emphasize that the goal of therapy should be a rapid, preferably within the first month, and deep hematologic response, at least a very good partial response. Ideally, all patients should achieve a complete hematologic response. The treatment should be risk, clone, and patient adapted, even among non-transplant patients, even with one officially approved regimen. Not all patients should receive the same regimen. And cardiac stage is not the only factor affecting the choice of therapy. And also, I would like again to emphasize that we should follow the response very closely and be ready to adapt our therapy. And with that, I would like to thank you very much for your attention.